Let's go. I don't want to do anything anymore. A 66-year-old man is brought to the office by his daughter who's visiting from out of town. The patient retired 8 months ago. For the past 3 weeks, he's felt depressed most of the day, nearly every day. He's had a markedly diminished interest in things that used to be enjoyable. He's lost weight and has difficulty concentrating and remembering things. He frequently thinks of death and suicide. He was treated for depression twice before and responded to antidepressant medication. Okay, what's significant? Number one, his age is significant. His gender is significant. The fact that, do you think he lives alone? Probably lives alone, because who's the one that's bringing him to the doctor? It's not a wife, it's not anybody else, but the daughter who comes from out of town. So he might live alone, but we need to find out. He's depressed every day for at least 3 weeks. He's losing interest. What do we call that? Having no interest in things that are enjoyable. It's called anhedonia, absence of pleasure. He's losing weight, he can't concentrate, his memory is affected, and he thinks about death and suicide. What would be your primary diagnoses here? Major depression. Okay. Most people who have major depression, what would be differentials for you? We always have to figure out whether or not it's an adjustment disorder. And why do we think adjustment disorder here? Because there is a stressor. And what was the stressor? The fact that he retired 8 months ago. So that's important. But why is this not an adjustment disorder? Look at the time frame. This occurred 8 months ago. But how long has he been feeling this way? 3 weeks. So did it meet that 3-month window of opportunity? No. Let's assume it did meet the 3-month window of opportunity. He retired 2 months ago, and now this is what he's feeling. Would you call it adjustment disorder, or would you call it major depression? It is still major depression. Why? Because it meets criteria for major depression. I try to explain it in a medical way. I don't think I'm ever successful, but here it goes. You go into the hospital with fever, chills, and cough. What's your admitting diagnoses? Do you say pneumonia, fever, chills, cough? Is that what you write? A pneumonia on an admitting diagnosis? What about an upper respiratory tract infection? Rule out pneumonia, right? URI, rule out pneumonia. Patient gets an x-ray, you find a right lower lobe pneumonia. What's your discharge diagnosis? Pneumonia. Do we treat it differently? Can you treat it differently? Okay, what if it's a viral infection versus a bacterial pneumonia? Do we treat it differently? Yes. Is one worse than the other? A mild cold versus a pneumonia? Same thing applies here. Now transform that into the psychiatric world. The upper respiratory tract infection is an adjustment disorder. It's very mild, it's very broad, there's no treatment. Major depression is the pneumonia. We need to treat, we need to get active, because if not, can this patient die? Yes. Can the pneumonia patient die? Definitely. Does that help you? So if you meet criteria for depression, call it depression and don't call it an adjustment disorder, because an adjustment disorder is something very mild. Remember, there's no treatment. Physical exam, of course, is going to be normal. He's oriented to time, place, and person, but he's slow to respond to questions, and he says he just wants to go home and rest. He probably wants to rest for a long time. So what would be your differentials? We've talked about 2 of them. We talked about major depression, also adjustment disorder, which I discussed. Why dysthymia? Why is that a differential? Because dysthymia is when you have depressed mood for more than 2 years. Yes, bipolar disorder, I threw that in there. Why? Because you can have depression and bipolar disorder. So we need to ask about previous manic symptoms. If the patient says no, get bipolar disorder out of your head. It's not existing because he's never had mania. So if mania is not in the picture, then what do we not rule in? We don't think of bipolar disorder. So let's see. Since we were thinking of thyroid, we know you're going to do a thyroid test, and of course it's going to come back normal. Let's talk to him. Let's talk to his daughter. Let's talk to as many people as we possibly can. He's had no previous manic episodes, no delusions or hallucinations. So what did we immediately rule out? Bipolar. He thinks that if he decided to kill himself, he would close all the windows in his apartment so as to not disturb anyone and use his handgun. So has he thought about suicide? He's got a plan, so that's very important. He's 66, he's male, and he's got a plan. What do we do for this man? Now, I'm not going to put up major depression or anything else because I think we've already discussed it, right? The differentials, correct? So we're just going to go straight to treatment. I don't want to put the slide up before we talk about it. What would be the first assessment of this patient? You ask the patient, do you have thoughts about suicide? Yeah, I think about suicide all the time. Do you admit him or not admit him? If there's nothing else in the case, you admit the patient. If that's the last word that came out of the patient's mouth, yes, I think about suicide all the time, then your answer at the next step in management is to admit the patient. Let's pretend there's another question. Do you think about suicide all the time? Yes, I think about it all the time. But would you do it? No, I would never do it. Why? I don't want to leave my children alone. I don't want to do that to my family. I know that it can be very devastating, and I do not want my family to suffer knowing that I killed themselves. So do I want to die? Yes. But would I ever do it? Never in a million years. Now I ask you, do you admit him or do you not admit him?
No.
Who would admit him? Who would not admit him? You wouldn't admit him. Why? How many of you have thought about suicide? I'm sure a lot of you here have thought about suicide. When you say something like, oh yeah, I wish I were dead. If I were dead, none of these things would happen. I wouldn't have any problems. It's very common to think about suicide. So having thoughts about it means nothing. But having intent, that's what's most serious. Do you want to die? And that's the question you need to ask your patients in the real world. Unfortunately, on the test, very rarely do you see that appear on the test. So anybody who's suicidal for the test, you do what with them? They go in because there's nothing else given to you as far as the case is concerned. So this man, because he tells you what he would do if he decided to kill himself, this seems like a plan to me. So is he an innie or an outie? He goes in, exactly. So we hospitalize the individual. What else do? We get the informed consent. We talk about medications. We go over all of the medications with him, which you know already, the SSRIs, the TCAs, the MAOIs. He's 66, I believe. What would you recommend as first line? For the purpose of the test, still, SSRIs are the answer. Now, I know there's a lot of studies out there that will tell you the following. If someone is old, then use a TCA rather than an SSRI. Why? Because the SSRIs can make the elderly a little bit more agitated than other people, and the TCAs might be more sedating. That's all fine and dandy in some research studies. But still, for the purpose of the exam, what you need to know is side effect profile. A happy patient, like I've told you, is a compliant patient. Why? Because they don't like the side effects. So if you give them a drug that doesn't give them side effects, they're going to take it every day. And if they take it every day, what will happen? Hopefully, their depression will get better. But this is the problem with antidepressant medication in patients who are severely depressed. You need to make sure that you see these patients sooner rather than later. Do not give a depressed patient who you're seeing for the very first time, who tells you he thinks about suicide but now would never do it, a 3-month supply of antidepressant and tell him, come back in 3 months to see me. Because you know what's going to happen the next time? He will not be back because he's 6 feet under by this point. The risk of antidepressant medication occurs when the patient starts to improve. So when you have people who are depressed and you treat them with antidepressant, you will notice that the risk of suicide, instead of going down, the risk of suicide goes up. And it's only for one reason. It's not that the medication makes you kill yourself, like the problem that fluoxetine had a few years ago. Prozac doesn't make you kill yourself or kill other people. What happens is that you get your energy back first. That's one of the things that kicks in first. So you've got a patient who's depressed, who's suicidal, who's got no energy, who's got no motivation, who just lies in bed and says to himself, I'm a miserable person, I wish I were dead, but you know what? I can't get up and go to the kitchen and get a knife and stab myself, or I can't get up and take pills. I'm not motivated. I just want to lie here and just stay here. They start taking their antidepressant medication. What do you think happens? I'm depressed. I don't want to live, but guess what? Woohoo! I got all this energy. I'm going to go into the kitchen and I'm going to take the pills and I'm going to swallow them. So you have to be very careful with these individuals, and you have to monitor them very closely. So that's why, personally, I bring my patients back in the in the office, within 2 or 3 weeks of me starting the medication. I want to see them. I want to see how they're responding to it. I want to ask them again about suicide, because it's very important. Does it mean that you have to see them every 2 to 3 weeks? Of course not. But you definitely want to see them sooner than 3 months from now. Let's assume that he does not improve on the medication. We have him on fluoxetine. Antidepressants typically take 2 to 6 weeks to work. What's the number one cause of relapse? Non-compliance, right? The patient doesn't take the medication. What's the number one cause of drug failure? Why does fluoxetine not work? Why does sertraline not work? Why does paroxetine not work? Is it our fault or is it the patient's fault because they don't take it properly? It's our fault because we don't prescribe it properly. And that's something that you need to be very careful when you're prescribing medications and for the purpose of the test. If I have a drug that takes 2 to 6 weeks to work, and I give the drug to the patient, and the patient comes back a week later and says, Doc, this drug isn't working, what do you think a lot of doctors do? Believe it or not. They basically switch the patient to another medication. I see it. This is the first time I've been in private practice. You know, I worked for the state of New York for many years, so I didn't have any private patients. And I see it in my office every single day. The patients come in, they've gone to an internist, they've gone to a family practitioner. I don't mean to say this to anybody, but that's typically what happens. How many days do these specialists spend doing a psych rotation? 1 month when they were medical students, a lot of them, or whatever the drug rep tells them when they comes to visit them at the office. So what you have is the patient gets started on tiny doses of medication. A few weeks later, nothing is working, and of course you're not going to get anything to work after a couple of weeks. The patient gets switched to another antidepressant. The same thing. A few weeks on that, tiny little doses, and the patient gets switched to another medication. So by the time you've exhausted everything, and maybe a year has gone by, then the patients get sent to the psychiatrist. And the patients will tell you, Doctor, I've been tried on everything. I'm a very difficult patient. There's nothing you can do for me. Well, how much have you been on? What was your dose of fluoxetine? Oh, 10 milligrams. And what was your dose of sertraline? Oh, 25 milligrams. Did you ever go up to 200, 300 milligrams? Oh, no, never. So they never go to a maximum dose for a maximum amount of time. And that's what you need to do before you switch from drug A to drug B. So start them on the antidepressant. Weeks go by. 6 weeks go by. Nothing. What's your next step? Or maybe some effects. What's your next step? Raise the dose. Wait a longer time. Nothing. Raise the dose again. So you go up as high as you can before you switch to another medication. And that's what's very important. So for this individual, let's say that we switched him. He's on a medication. He's saying it's not working. I've increased it. He's been on several medications. Nothing is working. Now, what can we use for him, the 66-year-old male who thinks about suicide? Then we have electroconvulsive therapy. So when is ECT used? ECT is used when the following are happening. Number one, you have many medical problems and side effects are worse than the side effects of ECT, so you prescribe ECT. Or number two, a patient who's very suicidal, and by that I mean you've tried to kill yourself at home, you've tried to kill yourself in the hospital. Is it going to do me good to just keep raising your medicine to hope it works? You're just going to, if you're so determined, you're going to kill yourself. So someone who's very suicidal, you're going to use ECT. Another reason to use ECT is what? The patient that medications have failed. So the meds aren't working, you're worried about side effects, or your risk of suicide is very severe, then you use electroconvulsive therapy. Especially in the elder patients, because you know they have a lot of medical complications. So can you use ECT in someone who's pregnant? Yes. Can you use it in someone who had an MI? Yes. Can you use it on someone who's got pacemakers? Yes. Can you use it on someone who's got seizure disorder? Yes. So if you have a depressed, pregnant female with a pacemaker who had an MI 3 weeks ago, can you use ECT? Yes. Benefits must outweigh the risks, of course. What is the contraindication of ECT? It's not an absolute, but it's a relative contraindication. It's increased intracranial pressure, because ECT itself will raise the pressure. So if you were to have any space-occupying lesions, for example, that would be a risk that is too severe. So ECT would not be used. But it's safe, it's effective, and it's considered the best treatment for depression. Not the most common, not the most likely, but the best. But because of the stigma of ECT, how many of you here would want ECT? One person. Nobody wants ECT. So you basically have to educate the patient, educate the public. Okay. So we treat him. We are determining, he's in the hospital, he's in the psychiatric facility. Who else have we contacted? Did we call social services? What do you think? Why did we call social services? Does he live alone or does he live with family? He lives alone. Maybe they need to evaluate him for home health care. Maybe he needs someone to come to the house to make sure that he takes his medication. Maybe he needs help with any kind of living at the house. So these are all things that the physician does, that the social worker does. We want to make sure that he goes back, that he's got a support system. Another thing that's very good for the elderly is those occupational therapy programs. You've heard of daycare for babies, right? Well, think of daycare for the elderly, where the little van picks them up in the morning, takes them to the center, they play bingo, they do art, they take classes, they go on big buses to the movies, they take day trips. You've all seen these buses, I'm sure. They have lunch there, and then what do you do at the end of the day? You take them back home. What do you think that does for an elderly individual? What's one risk factor for the elderly in suicide? Isolation. The more alone you are, the greater the risk of suicide. So having those types of programs for the elderly is very beneficial. So the social worker will help you find one of these programs for this individual. Of course, assuming that he wants to be involved in that program, because I can't force him into it, because he still has the capacity to give consent. Once discharged, before that, how do we assess whether I can discharge him or not? What should be your first question to this man? Does he still think about suicide? Does he still have a plan? If he says, yes, I still think about it and I do have a plan, and the moment you discharge me, I'm going to do it, you do not let go of that patient and you keep him in the hospital, and maybe you do other types of treatment. Now, a little earlier, one of you was asking me, if group therapy doesn't work, do you do individual? If individual doesn't work, do you use behavioral? That's not how we treat people in psychiatry. In psychiatry, it's an all or none. I am going to bombard you with every treatment known to man from the moment I see you. So I will give you medication, I will give you psychotherapy, and I will give you behavioral therapy if needed. It's not, if one fails, then I go to the next one. Everything is used at the same time, because we're dealing with mind, we're dealing with thinking, and we're dealing with learning. And all three have to go together. Okay? Do you feel comfortable with depression and how to treat it? Yes? Always SSRIs. Okay, we did that, we did that, we did that, we did that. Okay. The last psychiatry case is my heart has been skipping beats. A mother reports that her child engages in recurrent binge eating. She's heard her throwing up in the bathroom frequently. The child additionally exercises daily to the point of exhaustion. There has been no recent weight loss. She's 5'5", weighs 118, and has a blood pressure of 80/52. Physical exam shows poor dentition with a loss of enamel. Her teeth are chipped and ragged, and her parotid gland is enlarged. Her lungs are clear. Her heart is tachycardic with frequent skipped beats. There are calluses on the dorsal surface of her left hand. Well, it's obvious that this is a patient who has an eating disorder. When we deal with eating disorders, there's two main ones that you need to focus on: anorexia nervosa and bulimia nervosa. What's the difference? Let's see her here. She's binging and she is purging. If I were to stop the question there, right there, how many of you would put down as an answer bulimia? If you just see binge and purge. How many of you would put down anorexia if I stop the case right there? How many of you would say it could be both? Then that's the way to answer it. Because you will not concentrate on what the girl is doing, but I want you to concentrate on the weight and the height, how the girl looks, or maybe a reason why they're doing it. Anorexics and bulimics both binge and purge, so that is not going to be your differentiating feature. She exercises. She's 5'5" and weighs 118. How do we figure out what's ideal body weight? Now, this is a rough estimate. If you're a woman and you're 5 feet tall, you should weigh 100 pounds. Every inch over 5 feet, you add 5 pounds to it. So if you're 5, you're 100. If you're 5'1", you're 105. If you're 5'2", you're 110. If you're 5'3", you're 115. If you're a man and you're 5 feet tall, you should weigh 106 pounds. Every inch over, you add 6 pounds to it. So if you're a 5-foot man, you weigh 106. If you're a 5'1" man, you weigh 112, and so on and so on. So a 6-foot man, for example, should weigh how many pounds? 178 pounds, correct? Because it's 12 times 6, 72, plus 106. For you to meet criteria for anorexia nervosa, you need to have at least 15 to 20% loss of what's considered ideal. She should weigh 125. She weighs 118. That's 7 pounds lower. Does that meet criteria for 15 to 20%? Not at all. Another feature of anorexia is that they tend to describe in the question a body image disturbance. So these are the girls that they feel that they're fat even though they're very thin. And you don't see that here. Girls with anorexia have a problem with perception. They see themselves as one way when actually they're another way. Girls with bulimia don't have a problem with perception, meaning that they think they're abnormal or they view themselves as abnormal. What goes on in their mind is that they think of themselves that they have to look a certain type in order to fit the typical American woman. It's not that they view themselves as overweight or underweight. It's that they think they have to fit a certain body type. That's the main difference. Anorexia, she's 80 pounds, she's 6 feet tall, and she's convinced she's overweight. Bulimia, she's 5 feet 4, weighs 130 pounds, and bases who she thinks she is, or how she thinks of herself, I think that's a better way to describe it, on how she looks. So do you see the difference between both? Okay. So let's look at some other features. Poor dentition, loss of enamel. That means that she's vomiting a lot. Her teeth are chipped and ragged because of that, because of the vomit and the acidity. Her parotid gland is enlarged. You see this a lot, and this is a good clue for bulimia. Usually any salivary gland could be enlarged. If I were to remove the parotid gland, then some other gland would be enlarged. Okay, and you're going to find the tachycardia. And here you have the calluses on the dorsal surface of her left hand. You usually find abrasions or calluses on the backs of the hands and fingers. Why? Because they constantly stick their finger in their throat, and that rubs against the teeth, and that leads to abrasions. And you know, abrasion on top of abrasion, you're eventually going to end up with the formation of a callus. So from this presentation, what does it look like right off the bat? It looks like bulimia nervosa. But what's going to be your big differential? It's got to be anorexia. So let's look at individuals with eating disorders tend to have electrolyte imbalances. So you always have to make sure that you check all of the electrolytes. You check glucose, because they tend to have hypoglycemia. You also check EKG. So what do we find? Her sodium is 132. Her potassium is 2.8. Her BUN creatinine is 40 and 1.3. Glucose is 65, and the EKG is 110 sinus rhythm. How are the electrolytes? Abnormal or not abnormal? Abnormal? Okay. Let's talk to her. She says that she's depressed about her inability to control her eating. She says she must maintain her weight and seems to base her self-evaluation solely on body weight, is how she perceives herself. Denies the abuse of laxatives. So far, based on what she told you, not what she presents as, but just on what she verbalized to you, what does that criteria fit into? Forget everything else of the history. Concentrate on her words. She says she bases her self-evaluation solely on body weight. Is that typical of anorexia or is that typical of bulimia? What was anorexia? You look at the mirror and you feel you look like this, when in reality you look like this. That's a distorted body image. This girl feels that her worth, who she is how she looks like. In her mind, if she's overweight, people aren't going to like her. She's not going to think she's as attractive. If she's of normal weight, then maybe that's what she'll think. So which one is distorted, or more distorted, I should say? Anorexia or bulimia? Anorexia is completely distorted. This is just basing on what she looks like. Okay, let's go over the diagnoses here, which I've already covered most of it. So they have recurrent episodes of binge eating. A binge is when you eat massive amounts of food in a short period of time. And what they typically like to binge on are carbohydrate-rich food, cakes, pies, pastries, pasta, potato chips. They do it discreetly, so nobody sees that they're binging. So if you force them to eat with other people, what they'll probably end up doing is put less on their plate. And what they've done is that they've hidden food all over their house. So that when you leave the room, what do? They go to their food stash and eat all the food that's left over, because that's where they've hid it. And they tend to have a lack of control over their eating. They also, if you binge, you feel bad about yourself. So what do? You purge, and not only do you feel bad, but you feel sick if you eat a lot of food very quickly. You stick your finger in your throat and you vomit. And when you vomit, how do you feel? Shame, disgusted with what you've done. And basically this cycle just keeps repeating itself. And in order for them to stay approximately normal weight, what do? They abuse laxatives, they abuse diuretics, they exercise, they fast, and of course, they also purge. And they do it at least twice a week for at least 3 months. And again, it's their self-evaluation based on body shape. Now, the treatment of bulimia is unique in that, if you think of neurotransmitter theories, serotonin has been linked to bulimia nervosa. And one of the things that's interesting is that when you vomit, what do you think? So these are girls who they think have low levels of serotonin. So when you vomit, what do you think happens to your levels of serotonin? Your levels of serotonin eventually go up, sort of. So I don't want to say, this is not what I'm saying. It's sort of like a self-medication hypothesis, but that's not what we're thinking of. So the treatment for these girls is, of course, giving them an SSRI so that their levels of serotonin goes up. Anorexia is much more severe, much more pathological, very severe disorder, which can be very lethal. It tends to occur when they're younger, also seen more common in girls and boys, just like bulimia nervosa, except they have that body image disturbance. So they feel fat even though they're very thin. They also have the drop of ideal body weight, like 15 to 20% loss of ideal body weight. And you also have the amenorrhea. That's also very common. So if you're facing a girl with anorexia versus one with bulimia, which one do you think needs to be put in the hospital before the other one? Which one's sicker? Anorexia is much sicker than the bulimia nervosa. So anorexia definitely requires hospitalization. And bulimia probably requires pharmacotherapy, medication. Do they both benefit from behavioral therapy? Definitely. Do not allow the girl with anorexia to weigh herself every day. Do not allow the girl with anorexia to control everything that she eats, because their issue is one of control. What do you do with the bulimia girl as far as behavioral therapy? Allow her to eat and maybe lock her up in a room for X amount of time. What are you stopping her from doing? You're stopping her from sticking her finger in her mouth and vomiting. So these are all behavioral techniques that can be used. So let's look at the treatment. Let's go back and look at the electrolytes for this girl. Are they that off, or is it something that could easily be corrected with IV fluids? What do you think? Really bad or not that bad? Kind of borderline, right? So if this is a girl, what was her final diagnosis? Bulimia nervosa. Do you need to correct all these electrolytes? Yes. So what could the girl do? They go into the hospital. They go into the emergency room. You stick an IV in. You correct everything in the bag. Check the electrolytes again. And what are the chances that the electrolytes will be normal? High or low? Very high. Do we keep that girl in the hospital? Does she pose a danger to self or others at that time? Does she need immediate hospitalization? No. What do we provide for her? Medication. What kind? SSRIs. If this were a girl with anorexia, the picture changes. Why? Because this girl can die. And you would not get these electrolytes, trust me. The electrolytes in anorexia would be very, very, very distorted. These are all minor changes. And the treatment of anorexia will always be hospitalization. One of the things I like to ask is, what kills the girls with anorexia nervosa? What electrolyte is it? It's usually potassium. Hypokalemia. What do these girls die of? Cardiac arrhythmia. So that's their number one killer. So the girl with anorexia, what else do you want to make sure that she's attached to? Do you need cardiac monitoring? Yes, you definitely need cardiac monitoring. One other thing, let's talk about overdoses. Tricyclic overdose. Of all the medications that I can prescribe, the one that's most lethal is the tricyclic medication. So if someone comes in with an SSRI overdose, do I need to put them on any kind of monitoring? Not necessarily. Do you always get monitoring? Of course, because that's the standard of care. Same thing with benzos, same thing with any other medications I typically prescribe. However, tricyclic antidepressants affect the heart. They do cause conduction defects. So you better make sure that you order a monitor. Make sure that they're being checked when you have someone who has a TCA overdose. And 2 weeks of anything usually is enough to kill us. If we're going to commit suicide, a 2-week supply of any medication will be enough.